I want you to picture a scenario, one that you were probably intimately familiar with.
Oh, I bet I know exactly where you're going with this.
Right. You're sitting in that famously uncomfortable, overly reclined chair. The impossibly bright light is, shining directly into your eyes.
Yep. The dentist chair,
Yeah.
the absolute worst.
And you hear that high-pitched, menacing whine of the drill. You can actually feel the mechanical pressure of someone pressing a metal tool directly into your jawbone.
It's a deeply unsettling feeling, for sure.
It totally is. And you are fully awake. You are fully aware of what's happening. And yet, miraculously, you feel absolutely zero pain. I mean, how is that even possible?
It's one of those modern medical miracles that we just take completely for granted, you know?
Yeah, we really do.
We tend to treat the whole process as this binary transaction. Like, you get the shot, the area goes numb, you endure the drill, and then you just go about your day.
Right.
But underneath that incredibly routine experience is some of the most elegant physical chemistry and pharmacology in modern medicine.
Which is exactly why we're here. Our mission today is to unpack the science of local anesthetics, that almost magical ability to numb a specific targeted region of the body while you remain completely conscious.
It really is a fascinating mechanism.
Today's deep dive into our sources is just packed with wild medical history, some serious chemical ingenuity, and we are going to bust a few incredibly stubborn medical myths about how these famous procaine drugs actually work inside your body.
Yeah, there are a lot of misconceptions out there.
Okay, let's unpack this. When we use the term local anesthetic, what exactly are we defining?
So the modern clinical definition is quite precise. A local anesthetic is a drug that produces a reversible, localized loss of sensation.
And motor function too, right?
Yeah, often motor function as well. And it does this by actively blocking nerve impulse conduction in a very specific region of the body.
Yeah.
But crucially, it does this without causing any loss of consciousness. That last part is the defining characteristic that separates it from, general anesthesia.
Right, because with general, you're totally out.
Exactly. With a local, you stay awake, you are breathing on your own, your brain is fully online. But an entire nerve-supplied region of your body is just temporarily disconnected from the mainframe.
I love that. It's essentially a pause button for a specific nerve.
That's a great way to look at it.
But before we get into the molecular mechanics of how that pause button actually works, it helps understand where these chemicals came from.
Oh, the history is wired.
It really is. The sources map out this journey that starts with ancient botany, takes a really hard turn into accidental addiction, and then requires a massive chemical redesign. So where does this story actually begin?
Well, the timeline really begins in the Andes Mountains. Indigenous peoples there chewed coca leaves for centuries, utilizing them for their mild stimulant properties.
Right.
But they also noticed the numbing effects on the mouth.
So they knew it numbed things.
Yeah, they did. But the pharmacological clock really starts ticking in 1860. A German chemist named Albert Niemann, working in a laboratory in Göttingen, managed to actually isolate the active alkaloid from those imported leaves.
And he named it.
He named that isolated chemical cocaine.
Wow. Did he realize what he had just created?
Not fully, no. I mean, Niemann did meticulously record in his laboratory notes that the chemical made his tongue go completely numb when he tasted it.
Wait, he just tasted it?
Yeah, chemistry in the 1800s was a bit more hands-on. But that brilliant observation just sat there in the academic literature.
It just sat there.
Yeah, the medical establishment didn't do anything with that numbing property for over 2 decades.
That seems like a massive missed opportunity. I mean, when did someone finally connect the dots that this could be used for surgical pain?
So the person who started looking really closely at it was a young, highly ambitious neurologist in Vienna in the early 1880s.
Wait, is this Sigmund Freud?
Sigmund Freud. That is wild.
Hmm.
Yeah. He was investigating cocaine as a possible treatment for a whole host of ailments. Depression, severe fatigue, even morphine addiction. He even wrote this very enthusiastic monograph about it in 1884 called Über Coca.
Wait, so Freud is studying this chemical extensively, he's reading the literature, and he just completely misses the numbing effect for surgery.
He completely missed it. He was hyper-focused on the central nervous system, looking at mood, stamina, psychoactive effects in the brain, completely ignoring what the drug was doing to peripheral nerves.
So who actually figured it out?
It was actually his close friend and colleague, an ophthalmologist named Carl Kuller, who recognized the true clinical prize.
Okay, an eye doctor. That makes sense.
Right, because eye surgery at that time was excruciating and incredibly dangerous. Patients simply could not keep their eyes still while in agonizing pain.
Oh, that is a terrifying thought.
Kuller realized Freud's fascinating new chemical might solve his specific problem.
So Kohler decides to just, drop this newly isolated chemical directly into a patient's eye.
He did exactly that. In September of 1884, Kuller used a cocaine solution as eye drops, and he successfully performed surgery on a fully conscious, completely pain-free patient.
That must have been revolutionary.
Oh, it was. He presented this breakthrough at the Heidelberg Ophthalmological Society shortly after, and the technique spread through European and American medicine practically overnight.
Wow.
It was incredibly easy to replicate, and the results were undeniable.
Okay, but if cocaine was such an instant, overnight miracle drug for surgery, why do we have all these other caine drugs today? Like, why isn't the dentist just using a highly refined version of cocaine right now?
Well, because the medical community quickly discovered the drug's devastating shadow side.
The addiction.
Exactly. A brilliant surgeon in New York named William Halsted saw Kuller's work with eye drops and took the logical next step. Instead of just putting it on the surface of the eye, Halsted started injecting cocaine deep into tissues.
Like near the nerves.
Yes, near major nerve trunks, like the mandibular nerve for dental surgery. He essentially invented the concept of regional anesthesia.
Which is the exact technique we still use today.
It is. But to map out these nerve blocks, Halsted and several of his colleagues spent months experimenting by injecting themselves.
Oh, no.
Yeah. Tragically, they became deeply physically addicted. Halsted spent years fighting a severe, debilitating addiction, even as he went on to co-found the surgery department at Johns Hopkins.
That's so tragic. And our source material highlights this as a pivotal moment for pharmacology, right?
Yeah.
Chemists began to realize that the cocaine molecule was essentially a chemical accident.
Yes, exactly.
It had two completely unrelated properties bundled into one molecular structure by pure evolutionary chance.
Right, you had the specific mechanism that blocked the nerve, so the numbing, and you had a completely different mechanism, a neurotransmitter reuptake blockade.
Which flooded the brain with dopamine and caused the intense euphoria and addiction.
Precisely. One property doesn't cause the other. They just happen to be roommates sharing the same chemical scaffold.
That's a great way to put it.
And on top of the addiction profile, cocaine was cardiovascularly toxic, and it was chemically unstable. Like, if a hospital tried to heat sterilize a vial of cocaine for surgery, the chemical bonds would simply degrade and fall apart under the heat.
Oh, so you couldn't even sterilize it easily.
Nope. So, entering the 20th century, chemists realized they needed to act like molecular architects.
They needed to redesign the building.
Exactly. They systematically began stripping away the addictive stimulant baggage of the molecule while carefully preserving the structural scaffold that actually blocked the nerves.
And that led to Novocaine, right?
It did. By 1905, a German chemist named Alfred Einhorn synthesized a new drug called procaine, which the world came to know under the brand name Novocaine.
And that solved the addiction problem.
It successfully dropped the addiction risk, which was a monumental medical achievement.
But Novocaine wasn't the final answer. The sources say it had some pretty significant clinical drawbacks.
It really did. Procaine belonged to a chemical family called amino esters, and while it wasn't addictive, it had a very slow onset time, a short duration of action, and most problematically, the body broke it down into a metabolite called PABA.
PABA, like the sunscreen ingredient.
Yeah, very similar chemically. And PABA triggered genuine immune-mediated allergic reactions in a significant percentage of patients.
Ah, okay.
So it was a massive leap forward from cocaine, but it left plenty of room for improvement.
Which brings us to 1943. We have a Swedish chemistry student named Nils Lufgren and his colleague Bengt Lundqvist. And they synthesize a new compound called lidocaine.
And what's fascinating here is that lidocaine wasn't just another minor tweak to the procaine structure. It was the founding member of an entirely new chemical family, the aminoamides.
So a totally different structure.
Completely. It was built around a different chemical linkage, and that structural difference changed everything. Lidocaine had a faster onset, it penetrated tissue much more effectively, and crucially, it was metabolized in the liver rather than by enzymes circulating in the blood.
Which means...
that difference completely sidestepped the allergy problem that plagued procaine.
That is brilliant. It hits the market in 1949, and essentially becomes the undisputed gold standard.
Yeah.
But this brings up a huge question for me.
Sure, what's that?
We know these mid-century chemists successfully built a better, safer molecule. But how does that liquid in the vial actually intercept a pain signal? Like when the dentist injects lidocaine into your gum, what is physically happening to stop your brain from registering the drill?
To understand the mechanism, we need a quick primer on how a nerve fires in the first place.
Okay, lay it on me.
Think of a resting nerve cell. The inside of that cell is negatively charged compared to the surrounding tissue, resting at about negative 70 millivolts.
Right.
When that nerve gets stimulated, say, by a drill hitting a tooth-specialized structures in the cell membrane called voltage-gated sodium channels, suddenly snap open.
Okay, so if we imagine the nerve membrane as the solid wall of a highly exclusive nightclub, these sodium channels are the doors.
That is a perfect way to visualize it. When those doors snap open, positively charged sodium ions rush into the cell from the outside.
Flooding the club.
Exactly. The internal voltage rapidly spikes toward a positive charge, which creates an electrical impulse called an action potential.
And that travels to the brain.
Right. That electrical impulse travels down the length of the nerve, door by door, until it hits your brain, and your brain interprets that signal as pain.
So to stop the pain, we just have to lock the doors. We have to physically block those sodium channels so the sodium can't rush in.
That's the goal.
But our sources describe this wildly elegant two-step chemical trick that the drug has to pull off just to reach the lock.
Yes. Pharmacologists call it the neutral-in charged active mechanism. It all comes down to physical chemistry.
How so?
Well, these drugs are naturally weak bases, but in the vial sitting on the doctor's shelf, they are formulated as acidic salts like lidocaine hydrochloride.
Okay, so they're acidic in the vial.
Right. This makes them water-soluble so they stay stable as a liquid.
But the moment the dentist injects that acidic liquid into your tissue, it hits your body's natural environment, which has a pH of around 7.4.
Exactly.
And that sudden change in pH forces a fraction of the drug molecules to drop a proton. By dropping that proton, they become neutral, uncharged molecules.
And because they are uncharged, they become lipophilic, meaning they love fat.
Why is that important?
Because nerve cell membranes are made entirely of fat, a thick lipid bilayer. If a molecule has an electrical charge, it bounces right off that fatty wall. But neutral lipophilic molecules can slide right through.
Ah, so going back to our nightclub analogy, this neutral molecule is like a person in street clothes effortlessly slipping through the crowd and walking right through the wall of the club unnoticed by security.
That is exactly it. But once that uncharged molecule gets inside the nerve cell, the internal environment is slightly different.
Okay.
Inside the cell, the drug reequilibrates. A portion of those molecules pick up a proton from the internal fluid and suddenly become positively charged cations again. They become chemically bulky.
So they put on a massive, highly visible jacket inside the club.
Yes, and that charged, bulky version of the drug is the only form that can actually bind to the receptor.
Wow.
And the ultimate kicker of this entire system is that the receptor site is located on the inside of the sodium channel.
Wait, really? The inside?
Yeah. The molecule literally walks up to the door from the inside of the cell, wedges its newly bulky, charged self into the channel hinge, and physically jams it.
That is incredible.
The door cannot open, no sodium rushes in, no electrical impulse fires, and the brain never receives the pain signal.
It is a brilliant backdoor hack.
Yeah.
But it also seems incredibly fragile, because this entire mechanism relies on this delicate dance of dropping and adding protons based on the surrounding pH.
It is very fragile.
Which perfectly explains why you might have had a terrible experience with a numbing completely fail.
Exactly. This introduces a crucial pharmacological concept called pKa. A drug's pKa is the specific pH level at which exactly 50% of the drug is in that neutral form and 50% is in the charged form.
Okay, so 50-50 split.
Right. Most local anesthetics have a pKa between 7.6 and 8.9. Since a normal, healthy body tissue pH is 7.4, it means the vast majority of the injected drug is actually sitting in the tissue in its charged, bulky form, totally unable to cross the cell membrane.
Only a tiny minority of the drug is in that neutral lipophilic state, ready to cross over.
Exactly. The closer a drug's pK is to your body's 7.4, the larger that functional uncharged fraction will be. That dictates how fast the drug kicks in. Lidocaine has a pK of about 7.9, which is relatively close to 7.4, so it works very quickly.
But what happens if you're a patient showing up to the dentist with a brutally infected abscessed tooth? The environment isn't a normal 7.4 anymore.
It is a maddening clinical scenario. Infected, highly inflamed tissue is incredibly acidic.
Oh.
The local pH around an abscess can drop all the way down to 6.0 or even lower.
So if you're listening to this and you've ever had a nightmare experience where the dentist gave you shot after shot and couldn't get a tooth numb, it wasn't in your head.
Nope.
It wasn't a bad injection. It was literal physics working against the doctor. Because that infected tissue is so acidic, almost 100% of the drug gets trapped in that charged, bulky state outside the cell.
Exactly. The molecules can never drop the proton, they bounce off the cell wall, and the nerve just keeps firing.
Huh.
It is fundamentally a failure of physical chemistry, not clinical technique.
That must be so frustrating for dentists.
It is. The environment simply won't allow the drug to transition. But even in a healthy environment where the chemistry works perfectly, you might notice that these drugs don't turn off all sensations simultaneously.
Which is something I've always wondered about. Like, if this drug indiscriminately blocks sodium channels, why do we specifically call them painkillers? Why do you still feel the dentist forcefully pushing and pulling on your jaw or the vibration of the drill if your nerve is supposedly entirely blocked?
You are experiencing a phenomenon known as differential blockade.
Differential blockade.
The drug itself doesn't know the difference between a pain nerve and a pressure nerve. It just blindly blocks any sodium channel it can wedge itself into. But our actual nerve fibers are built very differently from one another, anatomically speaking.
Here's where it gets really interesting for anyone who's ever sat in that chair feeling pressure but no sharp pain. It all comes down to the physical size in the nerves.
Yeah, exactly. Nerve fibers come in different diameters, and some are wrapped in a protective, fatty insulating coating called myelin, while others are bare.
Okay.
The very first fibers to succumb to the anesthetic are the incredibly small, unmyelinated ones called C fibers.
And what do they do?
These specific fibers carry dull, aching pain, temperature sensations, and sympathetic autonomic signals.
So the dull ache and the temperature sensitivity go offline first because the fibers are tiny and easy to coat.
Precisely. Next to fall are the A-delta fibers, which are slightly larger and have a thin layer of myelin. They carry the sharp, lancinating pain signals. But the A-beta fibers, which are much thicker and heavily myelinated, are the fibers responsible for carrying the sensation of touch and pressure. They resist the drug significantly longer.
Wow.
And finally, the A-alpha fibers, the massive trunk lines controlling your actual motor function, are the very last to go down and the first to wake back up.
The sources explain this is due to something called critical length. For those larger insulated nerves, the electrical signal doesn't just travel smoothly down the line, it physically jumps over the fatty myelin coating from gap to gap.
Right, it leaps.
And those uninsulated gaps are called nodes of Ranvier. To successfully stop the signal, the anesthetic liquid has to coat and block at least 3 of those continuous gaps in a row.
That's the critical length, exactly.
That because the pressure and motor fibers are so physically thick, their gaps are spaced much farther apart. So it literally takes a larger volume of drug covering a larger physical distance of the nerve to knock them out.
Which perfectly explains the dental experience. The small pain fibers are easily blocked by a standard injection, but your large A-beta pressure fibers are just powering through the blockade, jumping the signal right past the drug.
That makes total sense now.
And this differential blockade also has profound real-world impacts in other areas of medicine, like obstetrics.
Oh, really?
Yeah. Take a laboring patient receiving an epidural. Frequently, their blood pressure will experience a sudden, significant drop before they even report feeling any pain relief.
Wait, why would numbing the spine cause a drop in blood pressure?
Because of those tiny, unmyelinated C fibers we just discussed, they don't solely carry pain signals. They also carry sympathetic nervous system tone, which is the constant signal telling your blood vessels to stay constricted.
Oh, I see.
So when the epidural fluid washes over the spinal nerves, those delicate sympathetic C fibers are knocked out almost instantaneously.
And without that signal, the blood vessels in the lower half of the body just suddenly relax and dilate.
Exactly, pooling the blood and dropping the patient's blood pressure. This sympathetic nerve block actually travels higher and faster up the spinal cord than the sensory pain block does.
That perfectly illustrates that these drugs are not perfectly isolated tools. The exact same chemical mechanism that works so beautifully to silence a localized pain nerve can trigger a systemic cascade.
Yes, they absolutely can.
Which brings us to the danger zone outlined in the sources. Because if these chemical spies end up in the wrong part of the body, the results can be catastrophic.
This requires a vital shift in how we understand these medications. We call them local anesthetics, but pharmacologically, they belong to a broader category known as Class 1B antiarrhythmics.
Meaning they actively alter the electrical rhythm of the heart.
Precisely. If a high concentration of a local anesthetic is accidentally injected directly into the bloodstream instead of the surrounding tissue, it travels rapidly to the brain and the heart.
Which is very bad.
Very bad. This causes a life-threatening emergency called local anesthetic systemic toxicity, or LAST. You have to remember, the human heart relies on its own vast network of voltage-gated sodium channels to maintain a rhythmic heartbeat.
Right, it needs those doors to open and close.
Exactly. If you introduce a drug that systemically jams all those doors shut, the heart's electrical conduction system simply goes silent.
The sources highlight a massive crisis regarding this in the late 1970s, involving the drug bupivacaine.
Oh yeah, bupivacaine was incredibly popular among surgeons because it provided a very long-acting nerve block. But emergency rooms started seeing terrifying case reports of sudden, completely unresponsive cardiac arrest when the drug was accidentally injected into a vein.
And the pharmacology shows it was because of how stubbornly bupivacaine bound to the heart tissue compared to something like lidocaine.
Right. It exhibits what pharmacologists call fast-in, slow-out kinetics. It wedges itself into the cardiac sodium channels incredibly rapidly, but it dissociates and releases so slowly that the body can't wash it out between normal heartbeats.
It essentially locks the heart's electrical doors and throws away the key.
That's a grim way to put it, but yes, standard resuscitation drugs like epinephrine often couldn't overcome the blockade.
But the solution to this bupivacaine toxicity is one of the wildest medical interventions in our source material. In the late 1990s, an anesthesiologist named Guy Weinberg pioneered a treatment called lipid rescue therapy.
It is brilliant.
So if a patient goes into cardiac arrest from systemic toxicity today, the protocol is to literally infuse them with an intravenous bag of white fat emulsion. Am I getting that right?
You are. It sounds utterly counterintuitive to pump fat into a patient in cardiac arrest, but the underlying chemistry is just brilliant.
How does it work?
Well, we established earlier that these drugs are highly lipophilic in their neutral state. They are powerfully drawn to fat.
Right.
The IV lipid emulsion acts as a massive chemical sink circulating in the bloodstream. It literally draws the lipophilic bupivacaine out of the cardiac tissue, pulling it away from the sodium channels and trapping it in the blood where it can't do any harm.
They flood the blood with fat to give the drug a more attractive target than the heart. That is remarkable.
It really is.
And that isn't the only bizarre systemic toxicity these drugs can trigger. If a patient receives too high a dose of specific agents, like lidocaine or benzocaine, it can cause a condition called methemoglobinemia.
Yes, methemoglobinemia. These specific molecules have the potential to oxidize the iron molecules sitting inside your hemoglobin.
And hemoglobin normally acts as the transport vehicle carrying oxygen through your bloodstream.
Exactly. But this oxidized form, known as methemoglobin, entirely loses its ability to bind and release oxygen.
So the patient's blood stops carrying oxygen and they literally turn blue. They become deeply cyanotic.
Yes.
And the danger here is that if a clinician doesn't recognize the specific chemical cause, their first instinct is to blast the patient with 100% supplemental oxygen.
Which will do absolutely nothing because the hemoglobin physically cannot accept the oxygen you are trying to force into it.
So what do you do?
The only way to reverse it is to administer a specific antidote called intravenous methylene blue, which chemically reduces the iron back to its normal functional state.
Wow.
It is a terrifying diagnostic trap if you aren't expecting it, particularly in pediatric cases where infants are sometimes given generous amounts of topical numbing creams containing lidocaine before minor procedures.
Definitely something to watch out for.
Mm-hmm.
With all these complex mechanisms and risks established, the sources also dedicate significant space to clearing the air around some massive, pervasive myths.
Oh, the myths are everywhere.
These are misconceptions that patients, and frankly, even some older medical professionals, still actively believe. Let's start with the most common one you probably hear in clinics every day. The allergy myth. The patient who states firmly, "I am allergic to lidocaine."
We encounter this constantly, but the pharmacological reality is that true immune-mediated allergic reactions to modern amide anesthetics like lidocaine are exceedingly rare.
Like how rare?
Statistically, they're almost non-existent.
So what is actually happening to a patient who has a severe physical reaction in the dentist's chair?
In the vast majority of cases, they're experiencing a vasovagal response, fainting or sweating purely from the physiological anxiety of the injection itself.
Okay, a panic response.
Exactly. Alternatively, they are experiencing heart palpitations and acute panic caused by the epinephrine.
The adrenaline.
Right. Dentists routinely mix epinephrine into the anesthetic syringe because it constricts the local blood vessels, which keeps the numbing drug trapped in the jaw longer. That rush of adrenaline can easily be misinterpreted by a patient as an allergic reaction.
That makes total sense.
Occasionally, a patient might have a mild reaction to the preservatives in a multi-dose vial, like methylparaben, but an anaphylactic allergy to the lidocaine molecule itself is incredibly improbable.
And the sources provide a very simple rule of thumb for clinicians to navigate this based on the chemistry, right? The two eyes rule.
Yes, it is a handy linguistic trick. The older ester anesthetics, the ones derived from procaine, are metabolized in the blood into a compound called pababi, which is a known genuine allergen.
Right.
Those older ester drugs have only one I in their generic name procaine, benzocaine, tetracaine. The modern amide drugs, which metabolize safely in the liver and almost never cause allergies, all have two I's in their generic name: lidocaine, bupivacaine, articaine, ropivacaine.
That perfectly transitions into myth number 2,
Hmm.
Novocaine. You hear people constantly say, I went to the dentist and got a shot of Novocaine.
Oh, yeah, all the time. But Novocaine is simply the original trademarked brand name for procaine, the drug Alfred Einhorn invented in 1905.
So they aren't actually getting Novocaine.
Nope. Dentists haven't regularly stocked or used procaine in decades because modern amides like lidocaine and articaine are significantly faster, safer, and more effective.
So it's just a lingering name?
Exactly. Continuing to say Novocaine today is the equivalent of calling every facial tissue a Kleenex or every vacuum a Hoover. It is a powerful brand name that completely outlived its actual clinical use.
Okay, myth number 3 is a massive one for any medical professionals listening, because this was taught as absolute, unquestionable gospel in medical schools for an entire century.
Yeah.
The epinephrine in digits dogma.
Yes. For 100 years, surgical textbooks adamantly taught that you must never, ever inject a local anesthetic mixed with epinephrine into fingers, toes, the nose, or the penis.
Because of the blood vessels.
Right. Because epinephrine powerfully constricts blood vessels, the established fear was that in these specific extremities, you would completely choke off the blood supply and cause the tissue to die and turn gangrenous.
But looking at the modern literature in our sources, this fear was totally unfounded.
Completely debunked. If you trace the original dogma back to the case reports from the early 20th century, you find massive flaws.
Like
Those early doctors were often using cocaine, which is its own potent vasoconstrictor, or they were using primitive, highly acidic, and poorly formulated epinephrine mixtures. In the early 2000s, extensive reviews of the literature, most notably a very famous review by Dr. Dinkler in 2001, found 0 confirmed cases of finger necrosis resulting from properly dosed modern epinephrine lidocaine mixtures in healthy patients.
So a century of medical students were memorizing a myth based on unverified bad data from the 1910s.
That's the reality of it.
Today, hand surgeons intentionally use epinephrine in the fingers all the time to reduce bleeding so they can actually see what they're operating on.
It is a humbling reminder for the medical field. We always have to be willing to interrogate our foundational assumptions and update our practices when rigorous new evidence arrives.
If we connect this to the bigger picture, why is understanding the profound nuance of local anesthetics so critical right now? Why does this matter beyond just making cavity filling tolerable?
It ultimately comes down to the ongoing opioid crisis. For decades, the default medical strategy for managing severe postoperative pain was simply to prescribe systemic opioids. But as the devastating addiction risks and side effects became impossible to ignore, surgical fields had to dramatically pivot.
And local anesthetics help with that.
Hugely. Today, advanced regional anesthesia using ultrasound to precisely target and block specific nerve bundles with these very drugs is the absolute cornerstone of what we call multimodal analgesia.
So the philosophy is about attacking the pain directly at the source, locking the specific doors of the nightclub, rather than altering the entire brain's perception of pain with a flood of systemic opioids.
Precisely. By utilizing targeted nerve blocks, patients can undergo major invasive procedures like orthopedic joint replacements or complex abdominal surgeries and wake up recovering with minimal, or in some cases 0, reliance on systemic opioids.
That is incredible.
It represents a massive paradigm shift in how we prioritize patient safety and recovery.
So what does this all mean? We started out high in the Andes, chewing ancient coca leaves.
Right.
We watched Sigmund Freud hyperfixate on the brain, while Carl Koller revolutionized eye surgery.
A lot of trial and error.
We witnessed William Halsted tragically succumb to addiction in the pursuit of regional nerve blocks. And from there, early chemists systematically redesigned the molecule, stripping away the euphoric dangers to create modern amides like lidocaine.
The molecular architects.
Exactly. These clever chemical spies utilize the body's own pH to sneak through fatty cell walls, don a charged uniform, and physically jam the molecular doors to pain from the inside out.
And they do it with such remarkable anatomical precision that your larger nerve fibers allow you to feel the intense mechanical pressure of the dentist's tools while completely sparing you the sharp, excruciating pain.
It is an extraordinary daily intersection of neuroanatomy, physical chemistry, and clinical medicine.
It really is.
And it leaves me with this final thought for you to chew on. If those early chemists were able to look at a highly addictive euphoric plant extract like cocaine and precisely snip away the devastating addiction while preserving this everyday medical miracle, what other revolutionary life-changing medicines are currently locked inside dangerous or illicit compounds right now, just waiting for the right chemist to separate the miracle from the toxicity? The next time you're sitting completely numb in that reclined dentist chair listening to the drill, just think about what future medical miracles might already be growing in the wild, waiting to be redesigned.